non-opioid analgesics. Now, whenever we say non-opioid analgesics, there is this non-opioid therapies. You can hear me kind of use them interchangeably. Analgesics primarily mean Tylenols and or acetaminophen and NSAIDs. We'll talk about acetaminophen, the dosing, side effects, place in therapy, contraindications, and key considerations in prescribing and agent-dependent characteristics. We will go through all these things with all the agents that we talk about today. So actually, let's go a slide back here. These are all the agents we're going to talk about. So we're starting here, and then we'll talk about some of the non-adjuvant agents, and then we'll talk about opioid agents. So, dosing. This is the one dosing I need you to know, Tylenol. Because Tylenol is in so many products, in OTC cold and cough medications, in pain medications, just in so many places that it is really important to, number one, monitor the amount of Tylenol your patient's receiving, and two, counsel patients on the amount of Tylenol they can get per day. So if you are prescribing, the max amount of Tylenol is 4 grams or 4,000 milligrams per day. For OTC labeling, that turns down to 3 grams per day. If somebody has liver disease or chronic alcohol use, that's whenever you use 2 grams per day. For the IV version of acetaminophen, if a patient is under 50 kilograms, you do want to use weight-based dosing. You do not need to know the weight-based dosing, but just know that you're supposed to use the weight-based dosing. It's actually a black box warning. The biggest side effect we worry about is liver failure. Thus, we have our sad little liver here. Place in therapy, sometimes first line for mild pain. Hold on, sorry about that, guys. Especially if contraindicated to NSAIDs. It has a little less efficacy compared to NSAIDs. So often, if you're going to only use one agent, use NSAIDs, although they are technically a little bit better tolerated than NSAIDs. So sometimes with mild pain, you can use Tylenol first. Overall, for our purposes, most patients will receive an NSAID first. Contraindications include hypersensitivity. Don't forget about the G6PD deficiency as a precaution, along with hypovolemia and noticing the dosing limits. You do want to try to avoid it in patients with a higher risk for liver injuries. And there's some listed here. Now, I will tell you guys, and this is going to blow your minds, but technically, according to the liver societies, you are supposed to use Tylenol first line in patients with chronic cirrhosis. The reason is because NSAIDs have an increased risk for bleeding. That being said, for our purposes, just kind of know that you want to be very careful with NSAIDs and liver disease. I would not put it on you guys to make that decision. Key considerations, always consider the dosing limits and note that they can increase the effects of vitamin K antagonist. So now that we talked about Tylenol, let's talk about NSAIDs. Once again, we'll go through dosing, although for this one, it is agent-specific. Side effects, place in therapy, contraindications and precautions, key considerations in prescribing, and agent-dependent characteristics. Side effects. Especially in NSAID overdoses, you do have an increased risk for CNS side effects, including headaches and tinnitus. Acetaminophen can cause bronchospasm. The reason is because it takes out all of the prostaglandin synthesis that is heading towards like pain management and platelets, and it takes it towards like what would be in bronchia. It usually only happens in patients with asthma, but it is something to keep in mind, and patients can have NSAID-induced bronchospasms. Cardiovascular speaking, you can have increased fluid retention, hypertension, and edema. Gastrointestinal, big things here is nausea, vomiting, and dyspepsia. you do have an increased risk for gastric ulcers, and I'm sure you guys learned that in your PUD lectures. Acute renal failure, this will come back to haunt us in renal, but you do want to make sure that you understand that. So that's why we have a SAD kidney as well as a heart. Decreasing in platelet function, which can increase bleeding and bruising. All NSAIDs carry box warnings related to serious cardiovascular and thrombotic events and GI bleeding. So that is something that you definitely need to know. It's usually first line for nociceptive pain. It's contraindication in patients with bronchospasm, asthma, and rhinitis related to NSAIDs. Avoid using heart failure or recent MIs. You do have a risk of SGAS in tens. That is more common with certain NSAIDs that we'll talk about later. Especially certain NSAIDs. If a patient has a history of PUD or a history of GI bleed, you can give it to them technically, but you may also want to give additional gastroprotective therapy such as a PPI or an H2RA. There are specific recommendations in the VA guidelines regarding who to give these therapies to. For our purposes, I didn't want to overload you with information, but just know sometimes you may give additional gastroprotective therapy. Another drug that can be used for this is misoprostol. Renal impairment, we want to avoid in patients with advanced renal disease, primarily not because they're going to have worsening of their kidney function, because that could happen, but because it has an increased bleeding risk. When somebody has liver or renal disease, they often have increased bleeding risk. This is the reason why. And you do want to try to discontinue if the patient has worsening renal function. A lot of times what this looks like on my service would be somebody's serum creatinine jumps by like twice or doubles, and that's the first thing I'll do is stop the NSAID. Agent selection will be based off of side effects, COX-1 and COX-2, and duration of action. So that's the thing to remember as we move on to the agents. And the drug interactions are related to increased bleeding, neurotoxicity, or nephrotoxicity, I apologize, including all these agents that are also nephrotoxic, and drugs that it can increase the concentrations of, such as digoxin and lithium. Now let's talk about specific agents. NSAIDs, side effect-wise, can be pretty well noted based off of their COX-1 or COX-2 selectivity. If you're more COX-1 selective, you have an increased risk for GI bleeding. If you're more COX-2 selective, you have an increased risk possibly of MIs and stroke. So we pick our agents based off of those things. Truthfully, all NSAIDs are equally potent. At equally potent doses. What that means is that no matter which agent I pick here, as long as I'm using the equivalent dose, they work just as well. So our selection really does fall into one, their side effects. So if somebody has an increased risk for GI bleeding, you might pick an agent that's down here in the COX-2 selective. If somebody has an increased risk for MI or stroke, you may pick something that is closer to non-selective or COX-1 selective. The other big thing that helps us determine which NSAID to use is their duration of action. Listed up here are agents with shorter half-lives like diclofenac, longer half-lives like paroxetine. One thing you'll also notice is the ones that have shorter half-lives are more likely to be for acute pain only. Quick on, quick off. Versus those with longer half-lives are more likely to be for chronic pain only, like paroxetine. These are going to take a longer time to come on, and they're going to take a longer time to come off. We will pick based off of this. So sometimes patients may want naproxen because it's only twice daily versus ibuprofen, which is 4 times a day. Instead of knowing the doses, I would want you guys to know relatively where these agents fall on the spectrum and where these agents fall on this spectrum. Now, as we talk about specific NSAIDs, let's start out with the COX-1 inhibitors. So, ketorolac is the most COX-1. So, as you guys are probably thinking as you're playing along, it's the most COX-1, has the most risk for bleeding or GI bleeding. It is so high that you actually can only use it for less than 5 days. And because it has a short half-life, it's indicated for acute pain only, and it must be initiated with an injection form. This is actually related to the side effects of GI bleeding. Indomethacin, it can be IV or PO. I did just put IV. You guys will see this used in gout. I think you guys probably have already heard about this, and patent ductus arteriosus in babies. It is slightly more associated with CNS side effects. That's its real claim to fame. Now, Bumetone, it does undergo a first pass effect. It's not even one of your guys' like top drugs. I would say that it and Sindelac are probably your lower. I do want you guys to know these side effects, but probably would be the least likely to be tested on. Let's just say they're the least likely to be tested on. So I'm just going to give these guys an FYI. Naproxen doesn't really have any specific side effects. It does, of course, have side effects. It's twice daily dosing. That's the reason why it gets used quite frequently, but it's nothing really specific. Piroxicam, it's actually only used in chronic pain because it has such a long on and off. Ibuprofen has interaction with aspirin's antiplatelet effects. You should take it 2 hours before or 6 hours after. Meloxicam has a higher risk of SJS and TENS, just like piroxicam, so you can kind of remember these oxycam. They also have some associated sulfamoides. Well, I take that back. They don't have associated sulfamoides, but they have that similarity. Similarly, you have the same risk for Indelac. Now, Indelac, I would say, is less likely to be tested on, as is piroxicam, because they are not one of your top drugs, and I don't see them used very often. Celecoxib is one of the COX-2 selective, and it actually is known as a COX-2 selective NSAID, like whenever it was designed, versus meloxicam, diclofenac are both considered more likely, more COX-2 selective, but they're not considered in the COX-2 selective class. Diclofenac and celecoxib have CYP2C9 interactions that you should keep in mind. Diclofenac does have an increased risk for hepatotoxicity. That is more than most. Celecoxib has been associated with decreased risk for GI toxicity. So overall, if you do have a patient that has a history of GI bleeding, pelvic ulcer disease, try to use one of these COX-2 selectives, and especially try to use celecoxib. Now, aspirin. Aspirin's a weird NSAID because aspirin, the rest of these NSAIDs are irreversible, and I know you guys probably are reversible inhibitors of COX-1 or COX-2, as you probably learned from Dr. Hingen, but aspirin itself is irreversible. This is one of the reasons why we use it for antiplatelets, because it has that 8 to 12 days over. Really is not used as a pain med often, and if it is, it's mostly because of like a legacy drugs like migraine meds that are combination pills, things like that. Remember that we do try to avoid aspirin in patients that are younger. That's why we have the no little kiddos, because it can cause Ray's syndrome, which includes encephalopathy, liver disease, and fatty infiltrate of the liver. It is especially as an higher occurrence after a viral illness.